it is a true privilege and honor for me to introduce Dr. Anne O'Gara for a WALS lecture. Anne O'Gara is a true pioneer in the field of immunology, and she made some numerous discoveries that have really changed our understanding of immunity, inflammation, and disease states. A few words of introduction about her trajectory. Anne first trained in the UK and as a postdoctoral fellow in immunology at the MRC in London. She subsequently moved to DNAX, that is of course a very historical landmark of immunology, first as a postdoctoral fellow, then as an PI, in which she defined fundamental function and mechanism for cytokine and immune responses. And really together her work was the first to provide a molecular basis for the process of immunoregulation via cytokines. Among the numerous findings of Anne O'Gara, I'm going to cite a few of them. She was the first to show that IL-10 could inhibit the ability of macrophages to sustain and induce Th1 responses. She was the first to show that IL-10 was able to suppress the production of inflammatory cytokines, and the first to show that macrophages themselves could be an important source of this immunoregulatory cytokine. In the context of another set of landmark study together with Ken Murphy, Anne was the first to show that the microbe can actually instruct APCs to produce both IL-12 and IL-18, thereby allowing the induction of protective Th1 responses. So together, this observation were paradigm shifting and really opened the door to the fundamental work that she conducted, as well as many others in the world, on the role of cytokine and in particular IL-10 in disease. And this really included the central role of IL-10 in the etiology of inflammatory bowel disease, the key role of IL-10 in microbial persistence, the regulatory role of IL-10 within the tumor environment, and many more. And because of her pioneering work in immunoregulation, she was really one of the first to propose the idea of a break of immunoregulation as a way to unleash immune responses, something that, of course, led to the advent of immune checkpoint therapy responses, and that is have transformed the field of immunotherapy. Upon her return to the UK, Anne became the head of the division at the MRC and Manuel Hill before becoming the associate director of the Francis Crick Institute in London. And really in line with the fearless attitude she had in research, she decided to apply her unique skill in cytokine immunology to an extraordinary challenge that is Mycobacterium tuberculosis infection. And once again in this field, she positioned herself as a leader by uncovering, using a system biology approach, a unique type 1 signature in the blood of patients. And this really allowed to uncover a role that was actually unknown before of type 1 and disease susceptibility via the regulation of both IL-10 and IL-12. And this, once again, changed our understanding of the factors that control the etiology of this disease. In recognition of extraordinary achievement, Anne received numerous awards and recognition. She's a Fellow of the Academy of Medical Science, Fellow of the American Association of the Advancement of Science, Fellow of the Royal Society, and many, many more. And in addition of all these achievements, I would like to say that Anne is also an extraordinary and formidable advocate for science in general, an advocate for young investigators, and an advocate for women in science. And I have to say humbly that I'm not sure I will be here presenting her if it was not because at one point in my life she adopted me as a mentee. So for all these reasons, I would like to say that Anne is really a role model and an inspiration for all scientists, and it's a true privilege for me to welcome her today for a WALS lecture. The title of her talk will be Cytokine Interference in Immunity and Infection.
Good afternoon, everybody. Thank you so much, Yasmin, for this very generous introduction. And thank you for inviting me to give this WALS talk at the NIH, which is a great honor, and also brings me the pleasure of visiting NIH again and talking with so many exciting scientists, including the early career postdocs and students. So my title is Cytokine Interference in Immunity to Infection, but a major focus will be on the immune response to tuberculosis. But I'd just like to just show you a few slides which actually led me to this. After finishing a postdoc at the National Institute for Medical Research in Mill Hill, London, I was very fortunate to obtain a postdoc position at the DNAX Research Institute in California. And one of the fantastic attractions there was that Tim Mossman and Bob Kaufman had discovered that CD4 T cells could explain the heterogeneity of many immune responses, and they had defined the Th1 cells producing interferon gamma important for macrophage activation and delayed hypersensitivity, and the Th2 cells, which they showed produced IL-4 and IL-5 at the time, important for B-cell responses, but most importantly, triggering eosinophils and mast cells. At that time, there was a lot of controversy in that were these clonal artifacts, et cetera, and Tim and Bob had obtained these from chronically immunized or parasitized mice, as had others. I used to come back to Mill Hill and be asked the question, do these really Th1 and Th2 cells really exist in vivo, and can they be driven? So that led me to start a program which I collaborated as a very early career group leader at DNAX, where I started my independent lab, where I had 2 people in my lab and collaborated with Ken Murphy to basically, in simple systems, show that if you triggered naive T cells to the T cell receptor and provided them with innate cells, macrophages and dendritic cells, and bacterial pathogens, this would then allow the T cells in vitro to differentiate along a pathway to Th1 cells producing gamma, and allowed us to isolate that interleukin-12 was an important factor in driving this Th1 response. Now, at this time, Bill Paul and his lab had defined that IL-4 was a driving factor for the Th2 response. And I'd like to take this opportunity to say that I will dedicate this talk to Bill Paul because it actually is his birthday today. And it was the first time I visited NIH. He was my host and was since very kind to me, supportive of my career. So after we found IL-12 driving Th1 development, many people started working on this, and through the years it was found that it was very important for protecting against many intracellular pathogens, Mycobacterium, Leishmania, Salmonella. On the other hand, the Th2 response was anti-helminth, as many of you have shown. However, if uncontrolled, both of these phenotypes could cause inflammatory pathologies such as colitis, allergic inflammation. So at that time, a cytokine called interleukin-10 was cloned by Paulo Vieira and Kevin Moore in collaboration with Tim Mossman at DNAX. And we found that B cells made interleukin-10, and so we were very interested in trying to find out why Tim Mossman had called it a cytokine synthesis inhibitory factor of Th1 cells, because the B cells could stimulate Th1 cells. And briefly, what we showed is that IL-10 was a dominant factor in inhibiting macrophages from producing IL-12 and TNF, dendritic cells in producing IL-12, and thus a great inhibitor of Th1 development. In addition, others showed that IL-10 could inhibit the killing of intracellular pathogens by inhibition of various factors. So that's research, and the molecular basis of it then took many, many years. And I stayed at DNAX from 87 to 2001. And I returned to the MRC National Institute for Medical Research at Mill Hill in 2001 to start the Division of Immunoregulation, to continue my molecular mechanisms of cytokine gene regulation, but also by discussion, it felt, since I was going to interface immunology and infection, that was my mandate, that I should work on a disease devastating to man. So I expanded my mouse models of infection to tuberculosis, which fitted with some of my past work on cytokines and bacteria, which I did my PhD on, and then went on to human studies. So what was known at the time of the early 2000s in the immune response to tuberculosis is MTB infects the lung primarily and basically can infect macrophages, and as Cliff Barry's more recently shown, neutrophils, and the cells will form a granuloma, which I will not talk about today. What I just want to point out is that naive T cells will then be stimulated in the lymph node by dendritic cells carrying mycobacterial antigens. And if you get a protective response, IL-12 and interferon gamma are protective, as shown in both mouse models and human disease, as well as TNF, where blockade in the mouse causes expanded tuberculosis, but also in humans treated with etanercept, anti-TNF drugs, where if exposed to TB will reactivate TB. But that was what was known. Because of what we'd found with IL-10 inhibiting macrophages and dendritic cells, we thought IL-10 must play a role in the immune response to TB, but at the time it was rather controversial. There were titles saying IL-10 plays no role in M. tuberculosis, and others saying you could see it in human. So we went to investigate this. bearing in mind that in infection, there had been various roles shown for TB, for IL-10. So IL-10 could suppress the immune response to stop pathology, for example, in malaria, T. shabodi, T. gondii, T. gruzii, with major pathology in IL-10 knockout. On the other hand, IL-10 could inhibit the elimination of the pathogen with little to observed pathology in various models, for example, in LCV infection. So what was the situation in TB? So setting up the aerosol model, which was not going at that time at Mill Hill, we found that IL-10 was induced at the protein level and in the RNA level upon MTB infection of mice. And then using knockouts, we found that indeed there was a decrease in the bacterial load, both in the lung and the spleen in IL-10 knockout, but no change in weight or no change in pathology. Now, these are relatively resistant mice, and therefore the decrease could be low, but this is somewhat significant for MTB, and others have since shown if you raise IL-10, this will really cause chronic infection. What we showed, however, is that this early and enhanced Th1 response was happening in the lung. In IL-10 knockout, you got increased gamma interferon producers. You could see this by the immigration of total number of gamma interferon producing cells into the lung. But this was early, and it waned after about 55 days. In the lung, you could see this increase in the knockouts, and in the serum, and as I said, this waned, showing that IL-10 suppressed the immune response early and subsequently had effect on the bacterial load. We've since shown, Lucia Moreira Teixeira in my lab, that it's IL-10's predominant role, IL-10's predominant role is in, from T cells, because targeted knockout of IL-10 in CD4 T cells showed the same inhibition of bacterial load as did the whole IL-10 knockout. Now, at this time, I did realize these are mouse models of TB. There was a lot of critique about these at this stage. However, many of the resistance factors had been defined in the mouse. We had now found a factor that may be contributing to suppression of the immune response in chronic TB. However, TB is a human disease. So we thought at that stage, I must work on human tuberculosis. So this is what I understood by a lot of studying with the clinicians, is that one person can be infected with MTB, and you can get a lot of deaths still per year, but a third of the world remains, may be infected or exposed, but remains asymptomatic. The clinicians informed me that diagnosis was problematic, drug treatment took 6 months, and the treatment monitoring was problematic. Now, many of you may not know that as well as in Africa and Asia having very high burden of TB, we also have cases of TB in the United Kingdom, in some pockets of England, but also in pockets of London, where in 2010, London was called the TB capital of Europe. So we started our studies in London and then validated them in an endemic country in Africa. And the question we were asking is, could we really see a difference between active TB and latent TB by looking at their global immune response? And the question was, why do certain individuals develop active TB whereas others don't? Could inflammation or particular type of immune response contribute to the progression of active TB? So the question is, what were the factors in the immune response contributing to TB? Could we see those in active TB, and were they missing in latent? And at that stage, having shown you those 3 slides that were like 10 years or 20 years of many people's work, I thought, I can't do it molecule by molecule. Could I do this by looking at the global immune response? And the question was, can human blood transcriptional signatures distinguish individuals with latent and active TB? And if so, give us some clues as to what's going on. And indeed, I led a study where we defined an interferon-inducible, neutrophil-driven blood transcriptional signature in human active tuberculosis, which I'll tell you the story about of how we did this study and what results we obtained. So we recruited individuals with active TB, suspected active TB, before they started treatment. We thought that would be important because we're looking at a blood signature which would be reflective of the immune response. We also took latent individuals that had to be positive for the interferon gamma release assay for MTB-specific antigens, or IGRA, which shows that they've been exposed but doesn't show whether they're going to go on to get disease, and then compared to controls. So the first thing we did was isolate RNA from whole blood of active TB and these controls. So the first test training set that we did, using statistics to get rid of any noise, we reduced the signature to a 393 transcript of whole blood that we could see in the majority of active TB patients. I will talk about the outliers later, but not seen in the majority of latent or control individuals. Now, these were each individual is a vertical and each gene is a horizontal, and you can see upregulated and downregulated genes. But before we could get excited about these, we really had to reproduce this study, validate it in maybe another London set and in Africa. So we validated this 393 signature in London, where we saw the majority of individuals with active TB having the signature and the majority of latent and controls not. And then we validated it in Africa, where all the individuals that were controls were IGRA positive. They were all latent, because that's what most people are in South Africa. But we could see that the same gene signature was apparent both in London and in a country of high endemic burden. Now, one thing that we did notice, and you could see these people diagnosed with active TB here in the clinic, but they clustered with a healthy. So the question was, I said to the clinicians, what could be going on? And you can see quite clearly that these individuals really look like healthy and not like the active TB. So Matthew Berry, a very bright medical clinician who was working with me at the time, thought to look at all the x-rays from all the individuals that we'd examined, and he and 3 other clinicians scored them separately and individually, and found that those individuals with a high radiographic sign of disease had a strong signature, whereas those with no sign of disease, even though they'd been detected in the clinic as possibly having TB, basically had no signature. And using a score from the x-rays and the molecular distance to health, which is the number of genes that are up or down regulated and to what extent they're regulated, the molecular distance to health, we could see a complete correlation between the lung radiographic side of disease and the molecular distance to health. And we think this is the first time that we could have a blood signature telling us what was happening in the tissue. Now, we went on to really show that this signature could be diminished on successful treatment, and then we validated this in another study where Chloe Bloom, another physician, recruited many more patients in London, South Africa, and you can see the whole signature is being diminished between 2 weeks, after 2 weeks, and this change in different individuals at different rates, and you can see each individual here that some have a very narrow slope, some have a dramatic slope, and therefore they're responding to treatment at different stages. And this really could advance the monitoring of treatment for new drugs and whether people are responding, since currently the test is sputum conversion, which takes over 2 months, and you cannot get sputum from over 50% of patients or more once they're being treated, and actually at the beginning only from about 70%. So this could provide a very quantitative way for measuring response to treatment. Now, this 393 blood signature was of active TB, but of course there was a lot of critique as to whether this would also be seen in other diseases. It was just an inflammatory signature, was what one of the reviewers said to us. We actually were very fortunate to be collaborating with Virginia Pasquale, Jacques Boncher, and Damien Chazabel in Dallas, the Baylor Institute, where Damien had come up with a solution for a lot of genes in transcriptional heat maps, and this was transcriptional modules. And the advantage of this is that the module is data-driven, does not involve the human being's manual selection. It maintains magnitude and complexity of data, but simplifies the presentation so you could easily compare it to other diseases. And the principle is it's based on k-means clustering, of which many of the other protocols are now based. In different diseases that they had in their database, you could see genes going up or down in the different diseases, but the genes clustered together, and then cluster 2 was another cluster, etc., etc. And this could be called module 1, module 2, and then when looking at the literature, you could annotate them with particular sets of genes that are annotated together, like B cells, T cells, interferon-inducible genes. And then we could now compare the TB sets, which are the training test set and validation set in South Africa, which all of you can see are completely superimposable, with group A strep and staphylococcus infections, which may be confounding diseases. And you can see that this interferon signature of interferon-inducible genes was there in TB, but not in strep or staph, at least very weakly, whereas they, in concert, had these plasma gene signatures in this module here, which was missing to low in the TB set. Then another autoimmune disease shared this interferon-inducible signature, which I'll come back to, and this was from Virginia Pasquale, and you could see that although this was shared, the TB doesn't have the plasma gene, and the SLE doesn't have some of these myeloid genes that are being downregulated. So you could start to distinguish between TB and other diseases. We went on to actually define that the transcriptional signatures could not only distinguish those diseases, but also pulmonary sarcoidosis, which can often confound diagnosis of TB, other pneumonias, and lung cancer, which, believe it or not, the clinicians will tell you can be confounding to TB diagnosis. At that stage, more recently, we reproduced our modular and transcriptional analysis in many more. It was reproduced by many in the field and shown to be pretty similar. And we then reproduced it by RNA-seq as opposed to microarray that we had been doing. And here we have the Berry et al., that's our first 2010 paper of active TB versus latent, London, South Africa, then Leicester, which is our new cohort of pulmonary and active TB patients. This is a study from Light Levine in Africa, Kafru et al., and this is a study from the Gates, Zak et al. Of active TB. And you can see very clearly that many of these interferon-inducible genes, which are now defined by a WGCNA, a new modular approach, could be seen across all the TB studies, and indeed lowering of T-cell signature could also be seen, and other modular signatures were also shared across all the TB studies. Now, after we published our study, 3 studies came out from the literature within a year. The MTB was shown to trigger the gasting pathway, and so could be turning on interferon similarly to other organisms, like possibly viruses. Furthermore, some strains of MTB shown by Margarita Saraiva et al., triggering through TLR4, can turn on more type 1 interferon. So this made us think, well, we've distinguished from all these diseases, but early viral infections may really also confound the signature. How does this look compared to viral infections? So we got various viral infections out of the literature and since got more. And you could see very clearly that indeed, as we predicted, the type 1 interferon-inducible signature was there in the flu, and both of these modules were there. And actually, a recent study has identified that a reduced gene signature, which you will need for diagnosis, however, when done with classical machine learning algorithms, actually all the genes in that diagnostic are in this module. And so we thought we need to be a bit more creative in this, and we could see that there were certain modules of genes like T cells and B cells that were reduced in the TB but were not affected in flu. There was hematopoiesis, which was turned on in flu and not turned on in TB, and so on and so forth. So what we could then do is go to each module and say, what is different between TB and the other diseases, select the number of genes that are different, and then apply the machine learning algorithm to reduce that to a number that can be used in the clinic. And so this shows, using the classical way that the Zak et al. Study showed, using the heat map, classical machine learning algorithm to distinguish TB, active TB from latent TB and controls. It did beautifully, and that's what it was tested against. But it wasn't tested against other diseases, and here you can see that in influenza, the actually control and influenza can be distinguished with that same signature. With the signature that we derived using this approach, of comparing not only using the modular but against other diseases. You could distinguish active TB from latent and healthy, but now you don't touch flu. And using, and we hope with bioMérieux to be able to develop this as a diagnostic in the clinic, and I should declare a conflict with respect to interaction with bioMérieux and bioAster, who have funded us for these studies. Now, using classical ROC curves that maybe many of you are very well associated with to show the specificity and sensitivity of our test, you can see in 3 different cohorts, our 20 gene signature picks up active TB from latent with high specificity and sensitivity, but it really has poor ability to pick up flu, whereas all the other reduced signatures that have been defined in the literature not only pick up TB, but they also pick up a viral infection. Now, people say, oh, flu is not relevant for TB, but it's just a surrogate viral infection. All viral infections turn on type 1 interferon, even the mildest ones that some of us have when we get a cold, as we found from many of our donors of healthy controls. We're keen to work on this signature to improve it further, but that will come with time. So a big question that really we also asked is, okay, so type 1 interferon may contribute to active TB. We can now see a way to distinguish active and latent, but could we detect a signature in early latent individuals, of which there are a huge number in the world, who are asymptomatic? Some of them may be subclinical and will progress within months to 2 years post-infection. And we've shown in our study and recently reported in reviews that actually active TB people infected with TB will actually go on to develop active TB if they're going to get it within 3 months, 6 months, 1 year, and the max we've found is up to 2 years. After that, unless they get a severe immunocompromised presentation, they remain healthy. So we wanted to look at these latent individuals further, and just to show you that we were suspecting this, because in our original heat map of our 2010 paper, we found that certain of these latent individuals actually showed this signature very close to active TB. And so if you look at these latent individuals together, you can see the heterogeneous, which had been proposed by Cliff Barry and Douglas Young a number of years before, and this really complemented this heterogeneity. But thus far, these individuals were asymptomatic, and this was a static point. Now, the question was, what was this signature? And in fact, just using these modules here again, the latent TB outliers we separated, both in the Berry combined sets and also in our Leicester new cohorts. And you can see that the interferon signature is starting to come up in the latent individuals, and here also. And these interferon signatures are 2 different modules, this one consisting of BATF3, ATF3, BATF2, ATF3, AIM2, which are known to be turned on by type 1 interferon, but also genes that, if you looked at them, OAS2, IFITs, which look like viral infection, but we know this is turned on by TB. In addition to this interferon-inducible signature being there in those outliers, we could also see in Leicester some of these NK and T cell module, which actually we now know is interferon gamma and TBOX21, very reflective of a Th1 signature, which seems to be being downregulated. We had missed that using the microarray. Now with RNA-seq, we could see it. But this is a static signature. These individuals were latent. People asked us if we could follow them. Of course, we hadn't the resources at the time to do that. So we started collaborating with Leicester colleagues, Pranab Halder and others, to really continue the studies. And this was a study that we took active TB patients, and they recruited them very fast, the contacts, to the clinic, and we got 109 contacts, 50 of whom remained IGRA negative and healthy over 2 years. 49 of the IGRA positive actually remained healthy also over 2 years, but 9 of these individuals went on to develop TB. And you can see actually from afar, this outlier of IGRA negativity is a very strange patient, and we keep asking the clinicians to keep following them, but all the rest have very, very little of this 20 gene signature. In the IGRA positive, we see this transient upregulation and downregulation within the months, and this was the months after recruitment, up to 2 years, in the blood signature in about 50% of them. But the signature went up and down, and they remained healthy over 2 years. But these individuals were with a persistent high blood signature in 70% are the ones that went on to get TB. And interestingly, 2 of these patients who didn't show a signature were on actual antibiotics called macrolides for pneumonia, which are known to suppress the immune response. So we need to avoid this in the future if we're going to use this to monitor treatment. And this 20 gene signature is what we're trying to use now to improve the early diagnosis of TB. And I just want to say that we're not stuck with this 20 gene signature. We're optimizing the reduced gene signature of TB and progressors over LTBI and other diseases using genes from all published reduced signatures, where many of them are not actually common. And 2 examples here where Olivia Tabon in the lab has now shown that these are controls, these are LTBI, and these are the LTBI progressors from our own study and Zach et al. Study versus the active TB. And you can see that you're starting to pick it up with one of the genes from one of the 3 of the other studies, whereas it's not seen in influenza, cancer, sarcoid, pneumonia, other viral infections or bacteria. And then this is another one from our own study which can distinguish between active TB and other diseases. And again, you start to get this diagnosis. And the aim is to really optimize a signature that can be brought together. We don't mind, what set in order to optimize being able to detect early TB and help early treatment. So before I get to the immunology part of the talk, I started this as an immunologist, but interacting with clinicians, seeing TB patients, made it my mission to help in trying to develop this for diagnostic. We need a reduced number of genes with high specificity and sensitivity, and also to help treatment monitoring. If we can detect early TB by a cheap way, this could also perhaps help in the treatment of this devastating disease. And this last part was funded by Biasa Biamaria, and our university hospitals, Leicester, are major collaborators. Now, as an I started this study as an immunologist to try and understand what factors contribute to people going on to get TB. And I alluded to the fact that one of those modules had this interferon-inducible signature. It was not only gamma interferon-inducible genes in the microarray, and then in the RNA-seq, we found actually they were downregulated, but factors induced by type 1 interferons. And so we asked the question, and we defined this further. Matthew Berry looked at this gene signature in many, many different ways. The modules, also genes downstream of the interferon alpha-beta pathway. And you could see that these genes downstream of alpha-beta were really upregulated. And you could see them upregulated in purified neutrophils from the blood and monocytes, portion of the genes, as compared to the whole blood, but not in CD4 and 8 T cells. And this was likely that they had been circulating after stimulation in the lung, but obviously that can only be proved in experimental models. But what surprises the most is that type 1 interferons, as we all know, protect against viruses, and in some cancers they can. But in Listeria and other basic models of infection, they'd shown to exacerbate bacterial infection. So why had this not been caught on in TB, and why hadn't it caught on in the mouse models? And so we went to the mouse models to look at mechanisms, and actually we then found 2 studies from Gilla Kaplan, 2001, 2005, where indeed she had shown that hypervirulent strains of MTB, H878, will induce high levels of type 1, which decrease Th1 immunity, and that the interferon alpha-beta receptor have longer survival times. However, not only was a different strain of bug, but it was also a different strain of mouse, not the regular B6 that we use in our studies. And so this, Alan Scher's lab then went on to publish, and Kat Meyer-Barber has continued a lot of work on this, in that showing that poly-IC treatment in MTB-infected mice caused a 2-fold increase in lung CFU, and this was interferon alpha-beta dependent. And we thought, well, there may be viruses, or removing negative signaling of the TPL2 pathway may do the same. So we postulated that early in an immune response, if a high level of type 1 interferon is seen either by hypervirulent MTB, genetics, or viral or adjuvants of the wrong type, this may lead to high levels of type 1 interferon, which could impact TB. And in the mouse model with Andreas Wach and also Kat, Meir Barber, and Alan Scher, we indeed showed that MTB infection in the context of influenza virus infection led to increased bacterial load, and this was completely abrogated in the alpha-beta receptor knockout, and that was viral infection doing it. Another way I suggested was perhaps releasing the brakes that are there to regulate the amounts of type 1 interferon during disease. And we went to this pathway downstream of pattern recognition receptors of TPL2 and MAP kinase, MEK, ERK, which we, together with Steve Lay at NIMR at the time, had shown would activate TNF and IL-10, but on the other hand, negatively regulate IL-12 and interferon beta. And if you took away TPL2 in basic models of LPS-CpG, we could see elevated type 1 interferon. So could it be that this could exacerbate the MTB in mouse models? And in fact, we looked at MTB infection and Listeria infection, and you could see in the TPL2 knockout, we indeed get an increase in bacterial load, as in the Listeria model. However, this increase of bacterial load was completely abrogated in the absence of type 1 interferon signaling. However, you don't see a phenotype in just with IFNA knockouts, which are on a B6 background. So in Listeria, you do see a phenotype with the IFNA knockout, but again, with TPL2 knockouts, you see this exacerbation, which is type 1 interferon dependent. So the mechanism we could look at in Listeria more because of the amount of cytokine made in the serum is that IL-10 was induced in the serum of these mice, and this IL-10 was abrogated in the absence of interferon alpha-beta receptor signaling, and accompanying this abrogation of TPL2 and IFNA signaling, you could see this highly elevated interleukin-12 production of huge amounts in the serum of these mice. So it looks like TPL2 and type 1 interferon are put in place in order to regulate the amount of cytokine you make in response to a pathogen in order to get a tempered response that can clear the pathogen. However, this obviously can go wrong, leading to chronic infection. So we wanted to understand more of how type 1 interferon may impede MTB control, and we looked at the macrophage and found that MTB-infected macrophages, when type 1 interferon is added to these, will induce IL-10 production in vitro, and this could be removed by removing type 1 interferon signaling. This could be seen at the message level in both cases, and actually type 1 interferon appeared to sustain the message, which in basic systems we've really demonstrated is transcriptional control to maintain IL-10 production. And in fact, addition of type 1 interferon also increased the stability of the IL-10 message. I won't go into the details of the assay, but clearly type 1 interferon in the setting of TB would turn on IL-10 and stabilize transcription and the message. So type 1 interferon in TB appears to be bad news. It turns on IL-10, it blocks IL-12 production from dendritic cells and macrophages, and blocks Th1 differentiation. And furthermore, we've shown it will actually block gamma interferon activation of macrophages. I haven't shown all of that for lack of time. But there's also a type 1 interferon paradox in MTB in humans. And there was one study in mouse with a different strain and a very low dose where it looked like type 1 interferon sometimes could be protective. So we and others have shown a positive correlation between type 1 interferon and disease in human. We've shown that elevating type 1 interferon can lead to increased bacterial load and disease. However, there were some clinical studies reported with both beneficial and deleterious effects of type 1 interferon administration during mycobacterial infections. So people had shown, these were case reports, beneficial effect of type 1 interferon when combined with antimicrobial therapy. That's key. Beneficial or no effect in patients with multi-drug resistant and disease TB. And the beneficial is when they were also administered drugs, and disease exacerbation in an active TB patient who actually had not been thought to have active TB, but they were receiving interferon alpha for viral hepatitis. So there the TB was obviously predominant. And to go back to the mouse, just to remind you that there's no phenotype in the mouse, although T-cell-derived IL-10 is reduced in IFNA knockout mice. You can see very clearly here. And I showed you that T-cell IL-10 was most important for leading to the increase of bacterial load. When you look at the viable bacteria, the IFNA knockout have no phenotype. The IL-10 knockout have a very dramatic phenotype. There are situations where we can bring the IFNA knockout to have a phenotype, but that is for another day. But the question was, why were we missing this? Now, when we looked in vitro at the macrophages, we saw that actually when we triggered with low amounts of MTB, early on we could see induction of IL-12, which was diminished in the absence of IFNA signaling, and in addition TNF, and this could also be seen at the message level. So early, and sometimes when you administered the cytokine before the MTB infection, you could actually, type 1 interferon could turn on IL-12 production. So there was this paradox. And so the question was, if you administered type 1 interferon early in low amounts of MTB or drug-driven TB, this may lead to IL-12 production. But the question was, were we missing the effect in the mouse models in this situation because gamma interferon was so dominant that it was masking any effects of protection on type 1 interferon? And so Lucia Moreira Teixeira in the lab used wild-type type 1 interferon receptor knockout, interferon gamma receptor knockout that we know are susceptible in the double knockout to see the effects. And you could see the CFUs using the IFNA knockout didn't change. When you took away interferon gamma receptor signaling, the bug load went up dramatically. But now, when you didn't have interferon gamma, you could see this increase in the bug load with type 1 interferon. This was accompanied by increase in lesions and inflammatory pathology in the lung. And so Lucia looked more at the mechanism, and basically this really fitted with type 1 interferon administration, showing to have a protective effect against mycobacterial infection in these patients with the interferon gamma receptor deficiency when they had been administered together with anti-MTB drugs. So therefore the bug load is low. And she showed that actually in these situations in her experimental model, she got an increase in TNF and NOS in the type 1 interferon receptor knockout in the absence of gamma signaling, and a decrease of ARG, and therefore leading to type 1 interferon causing the protection and explaining this mechanism. So I just round up with the model that I'll leave you with and what we're going to be testing in the future years, both in human disease and in experimental models. So early type 1 interferon will prime IL-12 and TNF production, provided that the MTB load is low, or in the absence of MTB infection or anti-TB drugs, and maybe that's our tonic signaling that we have there to turn on IL-12 and TNF at the beginning. However, once you get a type 1 sustained, late, high dose type 1 interferon signaling, which is really maintained for quite a long time, it can directly inhibit IL-12 and TNF. I didn't show that. It can turn on IL-10 to stop this pathway, and furthermore, it can block the ability of interferon gamma to activate macrophages and protection. So we really need to understand in experimental models in human disease is how the strain of MTB, the bug load, the actual load of the TB, and the environment or the genetics of the individual influence whether we have this low level of type 1 interferon or this high sustained dose, and what causes this tip of being able to progress to active TB. And so I leave you with this very basic question, which we will be asking by looking at the airways of individuals who are active TB or their contacts that I showed you earlier versus experimental models that we've now developed that look much more like the human disease, where we have changed the mycobacterial infection dose, the strain of the mycobacterial strain, and the strain of the mouse, and actually there start to get a signature that totally resembles human disease. And so that is the future, but it's been a long journey, and a long journey that's only possible through great people in the lab and great collaboration. So Matthew Berry was the first physician in my lab. They came for relays of 3 years. They had to go back to the clinic, then who really set up the study. Then Chloe Bloom joined with the treatment response, Simon Blankley, extrapulmonary TB. Christine Graham was a long-term member of the lab who's just retired, who sustained all the library prep and RNA prep from all these patients. Akul Singhania and now Olivia Tabon, other bioinformatics who've joined this study, which actually we started in collaboration with Jacques Bonchor, Damien Chosabel, and Virginia Pasquale, where we really learned to analyze data. Now we do it ourselves. And we have to thank the patients and the clinicians that we've collaborated with in South Africa, in London, on MinCon, Rob Wilkinson, and now Mark Lippmann for some of the other studies at Royal Free. And now our collaborators, Raman Verma, Joe Lee, Gerrit Waltman, and Pranab Halder in Leicester, where we have a very long-term collaboration. And the experimental mouse models were initiated by Paul Redford, then Finn McNabb, John Eubank, Vangelis Stavropoulos, really maintaining the whole show of training. And then this nice data that I've shown you from Lucia Moreira Teixeira, a postdoc in my lab, who's soon to be looking for group leader jobs, and Shumei supporting all our mouse work. And this is collaborations with Steve Lay, Andreas Vark at the Crick, Katmere Barber and Alan Scher here at the NIH, and Jeremy Souza and Margarida Saraiva in Porto, Portugal. And actually, she's my ex-postdoc who has gone on to have a successful career and is very helpful with us sometimes when we move to the Crick and didn't have the mouse model, the animal facility for TB for 2 years. I just want to make an important point to especially young people in the audience, is that I went back to the MRC, National Institute for Medical Research, and this is also important to NIH, where I was doing IL-10 and basic cytokine. I wanted to get into tuberculosis, and the grant funders had reviews that said, Anne O'Gara is a mouse immunologist, there's just no way she could do human TB research. So I just shifted my core funding to work on this. Then I was fortunate to get some money from the Dana Foundation. It was a very small amount of money for the first 2010 study. That then led to the Medicare Allowance supporting us, the ERC, and BioMérieux and BioAsta. And at last, now I actually got a Welcome Investigator Award to study human TB. So it's taken a few years, but now people acknowledge that, you know, mouse people can go into human studies. And I'd just like to point out the beautiful National Institute for Medical Research at Mill Hill, where much of this study was done and where many of you have actually worked, trained, which is now, I'm afraid, a flat piece of land to be built into apartments. And now the Francis Crick Institute, which is a very exciting institute in London, where we're conducting our work now. So please visit. Thank you very much.
The floor is open for questions.
Yes, where most of the tuberculosis cases are located in the developing world, there's often a co-infection.
Can you put your face closer to the microphone? Sorry, because it's hard to hear.
Okay.
Great.
Where most of the tuberculosis cases are located in the developing world, there's often a co-infection with HIV, et cetera. And there are often many other comorbidities that are not as well advertised, like malnutrition, et cetera. Isn't that going to affect your genetic signature and the effectiveness of it being used in its primary indicated area?
Absolutely. And indeed, we are collaborating with Rob Wilkinson and Graham Minges in South Africa, in Cape Town, where indeed they're studying HIV-TB, and we're helping them look, training their fellows to look at the early effects in HIV-TB tuberculosis, and indeed on other factors that may be affecting them. But one can't do everything, so the important thing is to train people in Africa in order to be able to conduct studies of the kind that you're indicating, and we're actually doing that. We have a Crick Africa network for training of postdocs at the Crick to then be able to go as group leaders to really ask these specific questions. The signatures you could see, looking at a broad set of people, was recapitulated, and this has been done by at least 15 other studies. However, one of the advantages of doing what we're doing, which is basic research in Leicester, is actually to try and understand the immune response, which is early and protecting versus going on to progress to TB, because there you have 10% progressing, 90% not. And we don't know what the basis of that is. And the advantage of doing it in Leicester, well, let me just say to those of you who think it's not a disease there. It's still a disease in low to intermediate burden countries, is that we don't get reinfection in Leicester. So we can look at one infection and see the progress on why some people progress and do not. In Africa, there's the complication that people may have been reinfected, and it's quite difficult to know. So one has to get the index case as well as the case of the people reactivating. So we've considered all these things. We can't do everything, but we do collaborate with people in Africa in order to answer some of the questions you're referring to.
Thank you very much.
Beautiful talk. In follow-up to your mouse results about co-infection with influenza, are there human epidemiologic data suggesting that conversion from latent to active TB is often associated with the occurrence of a viral infection such as influenza or others?
So this is a really good question, and it's one that we had put in our collaborative award to the Wellcome Trust, but it didn't quite fly, but we're going to do it anyway, although with obviously low numbers. But influenza was just a surrogate, and we have those other viral infections. So it's any type of type 1 interferon. So our clinicians in Leicester definitely go in and try and detect whether they have bacterial pneumonias or viral, and they do those diagnoses. They will do their best, but we know, and this is word from the clinicians, that to prove that somebody has a viral infection or bacterial infection, sometimes when it's cleared and then afterwards you'll get the TB, is very difficult. So we will do the best, and that's why I believe there are not epidemiological studies, because this is not going to be just flu. It's going to be flu, paraflu, RSV, whatever viral challenge that people may get. So it's an important question that we'll try and address, but the epidemiology studies are not there.
Thanks.
But that's the point of looking at early TB with Graham-Minges, because in certain individuals, before the CD4 counts have even dropped, you actually get people who have HIV, then get TB, and they go on to die. And so one wants to know before that, what are the events that are determining which way they go? So that would be another way of addressing.
I missed the first part of his question, but this is related, I'm sure. And you and I have talked about this often, but the audience would be interested. So do you think that the signature is really simply telling us that you have subclinical TB present? It's not really an immunologic signature that's telling you that you're susceptible to TB. Yeah.
So in the latent individuals where we had those outliers that had an interferon signature, it really looked like they may have subclinical disease. Now, in those transient responses in our IGRA-positive individuals that we followed, we didn't use the interferon response because that confounded with other diseases. We had this 20-gene signature that went up and down, whereas it was sustained in the other individuals. So something probably is different. But I don't think we're going to see it in the blood, and that's why we need to go in the airways to see what are the early events that happen that may determine whether people get a level of type 1 interferon that really makes them go on to exacerbate TB, whereas going and really downregulate it. So we believe from our mouse studies of looking at mouse lung versus blood that we will be able to get a better handle on this, and the aim is to look at these contacts versus those that progress or those that don't, at the different innate cells and the changes in them that occur very early in that immune response.
There's also another part of this story that's kind of emerging now, is that it appears that IGRA negative and PPD negative people can actually be infected. That those people that we thought were actually protected against TB. Have you seen signatures in people who are endemic normals that might be this group of people?
So the IGRA negative, as I said, we had a very small blip in them, but you could see something. However, just for the audience, the IGRA test, it detects gamma interferon. There are groups who are now showing that if you look at TNF instead, you can actually see a response to the MTB antigens. And there's another group, Jacobson and Tom Ottenhoff, who are doing, it's like a T-cell polarization, where they're actually taking the T-cells and giving 2 steps to see if they could just expand the T-cells that are responding, and they're seeing those in the IgRA negative. So it could be sensitivity, but clearly they may have responded. We don't know what percentage of those IgRA negative, but we have gone for the IgRA positive because those we had, the 9 that progressed, 8 out of 9 were IgRA positive, so we have a bigger chance with our bigger numbers to really get something happening. And then the IgRA positive who did not progress, they had that blip of a signature in the blood suggesting, okay, we're going to see a response, but they say it stayed healthy. But I think the IgRA negative, it's all been, that genetics, they don't respond or whatever, but I just wonder if it's just sensitivity. And what nobody thinks about, even in immunology, is the burden of the bug load and how much insult is the individual perturbed with.
Well, you covered the whole profiles of TB in different perspectives and sorted out at least the interferon role, interleukin-10, and interleukin-12. So is there any tissue specificity? If I have TB in the lungs versus in the bone, is there any other effect that might be augmenting or suppressing this TB response?
I think that's a fascinating question as to what else is happening to, in some individuals you get dissemination or not. It's very interesting that anti-TNF treatment of individuals who were latent actually leads to extra pulmonary TB invariably, and also HIV TB often leads to extra pulmonary TB. And so what is controlling the dissemination? And all I can say is, at the moment, we're not working on that, but by chance, Lucia, my postdoc, may start because we have a knockout where the spleens are this big when you give them MTB. And so that could be really exciting, especially that she could then, use that to follow her career as well as very exciting data.
I have a TB spot, so I am following up. And so I asked Jack Masur, I said that I had this spot when I was leaving Mayo Clinic. They showed me in the X-ray that you have this spot. So I was asking Jack Masur, what is the chance? Should I have 6-month therapy? He said, if you did not get it by this time, it's never going to happen. So,
well, I've heard people who had backache and were at the GP and they were given painkillers all the time. And one weekend they came into St. Mary's Hospital where they think about TB, and it had gone on for so long that they went to diagnose them. And in fact, they stopped the painkillers and gave them anti-TB drugs and they got better. So that was London. So, we're open to all. But anyway, thank you for your questions.
Great work. Thank you.
So I have one small question. I wanted to ask you that people are looking at the microbiome relationship with TB, but it will make more sense to look at the virome instead of the bacteria in terms of setting the tone of the type 1 responses, isn't it?
Yeah, that could be pretty important to see what other innate flora are affecting them going the wrong way, and the viruses could be very important. And so you as a microbiome expert, and we were discussing this with Alan yesterday and his postdoc, we were discussing, they study feces, and I was thinking I'd like to look at the lung and the sputum. What would you recommend? Probably all of it.
If possible, all of it.
All right.
Anyway, on that, I would like to, of course, I would like first to remind you that there will be drinks and cookies, non-alcoholic drinks and cookies at the library. And thanks once again, Alf, and for this fantastic lecture. Thank you very much.